Hi, it's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care so that you can make informed decisions, have peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered, and in last week's episode I answered another question from one of our readers and clients, and the question last week was, why does the ICU team intend to remove my mum's breathing tube and disconnect her from the ventilator to die? You can check out last week's question by clicking on the link below this video. In today's episode of Your Questions Answered, I want to answer questions from one of my clients, Bong, as part of my one-on-one consulting and advocacy service. Bong's mum is critically ill in ICU, and Bong is asking why the ICU team is telling that her mum has limited time on a ventilator. So today's question is, why does the ICU team say that my mum has limited time on a ventilator? You can also check out previous one-on-one consulting and advocacy sessions with me and Bong below this video by clicking on the links in the written version of this blog. So Bong writes, Hi Patrick, if IPV, intrapulmonary percussive ventilation therapy, had been used 2 weeks ago, it would have enabled my mum to recover faster, as it would have cleared her lungs earlier and reduced exhaustion from coughing and irritation to her throat from coughing with the breathing tube, thus increasing her tolerance for the tube. Treatment has brought up more mucus, but it leaves mum tired and unresponsive. I suspect it temporarily interrupts her air passages and her breathing. Before IPV, I was told about pockets of mucus that had settled in her lungs, but mum was at her highest awareness. IPV temporarily changed that, sending her back to sleep. I suspect it will pass. When mum first checked in and the one lung was collapsing, she was hard to arouse. The nurses recognized she wasn't getting enough oxygen as the cause. The problem is to conduct PE, pulmonary emboli. Mum has to be alert, and we have only 7 days. The nurse has never seen anyone in the ICU receiving PE. He says it is not performed in the ICU. That reflects the hospital's policy. You are either capable of recovering from the ventilator on your own or do a tracheostomy and move the patient to an acute care facility. Poor performers are given no help. I am told 21 days is the limit to have someone on the ventilator with a tube in the throat. Regards from Bong. Hi Bong. These are additional info regarding the use of IPV or intrapulmonary percussive ventilation. IPV or intrapulmonary percussive ventilation is a form of chest physical therapy administered to the airways by a pneumatic device. IPV is designed to both treat active pulmonary disease and to prevent the development of disease caused by secretion retention. Specific goals of therapy include promoting the mobilization of bronchial secretions, improving the efficiency and distribution of ventilation, providing an alternative delivery system for bronchodilator therapy, providing intrathoracic percussion and vibration, and providing an alternative system for the delivery of positive pressure to the lungs. The phasitron may be set to continuous percussion for use in intubated patients. IPV may be applied via mouthpiece, mask, artificial airway, or through a ventilator. To many, IPV is seen as a superior method of secretion removal compared to the traditional chest physical therapy, vibratory therapy, and other forms of oscillatory airway clearance. The contraindications are untreated pneumothorax without chest tube, hemoptysis, which is bleeding, active tuberculosis. Precautions. Patients should not receive IPV therapy immediately after eating. A period of at least 1 hour should be observed after meals before the initiation of therapy to minimize the risk of aspiration. Next, vital signs must be monitored and the patient must be continuously assessed during IPV therapy. Observe the patient's heart rate, respiratory rate, blood pressure, and pulse oximetry closely for signs of intolerance. Tube Feeding should be stopped for 1 hour prior to IPV therapy, and patients should remain at a 45-degree angle during therapy to minimize the risk of aspiration. Supplemental oxygen must be provided for patients requiring it, and the oxygen saturation should be monitored. Suction equipment should be immediately available at the bedside during IPV therapy in case of airway compromise due to copious secretion mobilization. To minimize the risk of barotrauma, also known as lung injury because of high pressure, a pressure pop-off or a valve must be utilized when using IPV for mechanically ventilated patients. Monitor peak airway pressures closely. Driving pressure of 30 to 45 psi must be used during IPV to achieve therapeutic effects. Always assess the patient's chest excursions to determine the appropriate driving pressure. An IPV treatment should be discontinued if a patient experiences any of the following: increased shortness of breath, chest pain, or an increased FiO2 requirement evidenced by transcutaneous desaturation, significant changes in heart rate or rhythm, blood pressure or skin color marked by diaphoresis, fatigue or emesis. Notify the doctors and the RN and continue to monitor the patient for progression of symptoms. Re-evaluate the indications for therapy. If a patient experiences difficulty in clearing secretion during therapy, assist the patient as needed with nasal or orotracheal suctioning. Next, documentation. The respiratory therapist or the critical care registered nurse needs to document the pre- and post-treatment clinical assessments, sputum production, medication, and dosage, including volume and total solution volume, and therapeutic driving pressure on the electronic medication record. Number 2, physiotherapy versus physical therapy. Physiotherapy indicates more of a hands-on manual therapy approach to rehabilitation, while physical therapy indicates a more exercise-based approach to rehabilitation. But according to research, both of these terms are synonymous. The very first thing your mum needs is to be referred to a certified physical therapist or to a physiotherapist to assess what type of physical therapy, which again is physiotherapy or physical therapy, tailored to what your mum needs, or if not, why they won't be able to perform it to your mum. They should be explaining their reasons to you as to why. I just wonder why they were telling that they can't do physical therapy to your mum when they can move her up to a chair. This is part of physical therapy. The physiotherapist should be responsible for implementing mobilization plans and exercise prescription and make recommendations for progressions of these in conjunction with other health team members. Number 3, likely the sleeping is because mum is not getting a lot of oxygen or is not expelling CO2 or carbon dioxide. Again, it all boils down to the current result of your mum's arterial blood gas to see her current blood oxygenation and CO2 levels. They should be performing blood gases as they see fit, but these assessments should be reported to the doctor immediately to treat the underlying condition. I hope this helps. For any questions, please let us know. Bong writes back, "Hi Patrick, the hospital is proceeding with removing mum from the ventilator at 3 p.m. today. I will try again with the cord for an injunction. I have a 7-day grace from the cord to delay tube removal, which if I take full advantage will exceed the 21-day limit for mum to have the tube in her throat. We are already seeing new blood, likely from the cuff, so I will be working tomorrow with the new doctor on the ward to condition my mum. Not a day can be wasted. Dr. Well is familiar with all treatments. He was citing them as he attempted to find justifications to remove my mum's breathing tube." Mum's blood results for today is as follows: white cell count 4.8, hemoglobin is 9.1, hematocrit 28.9, platelets 208, and glucose 101 from Bong. "Hi Bong, ask the hospital to give you their withdrawal of treatment policy as a starting point. They need to follow that. Every hospital has protocols for everything, starting from mopping the floor, cleaning windows, to detailed clinical procedures. Therefore, they must have a weaning protocol. The blood results are okay. Hemoglobin is lowish. We still need an arterial blood gas that has not changed. If we can set up a phone meeting with a doctor, we can propose a treatment plan. If they can't formulate a treatment plan, I believe that we can, and we can advocate for it on a clinical level. Let me know your thoughts. So this one-on-one consulting and advocacy session will continue in the next video. So, how can you become the best advocate for your critically ill loved one? How can you make informed decisions, get peace of mind, control, power and influence quickly whilst your loved one is critically ill in intensive care? You will get to that all-important feeling of making informed decisions, get peace of mind, control, power and influence when you download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn quickly how to make informed decisions, get peace of mind, real power and real control, and how you can influence decision-making fast whilst your loved one is critically ill in intensive care. Your free Instant Impact Report gives you in-depth insight that you must know whilst your loved one is critically ill or is even dying in intensive care. Sign up and download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn how to speak the secret intensive care language so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions. Discover the many competing interests in intensive care and how your critically ill loved one's treatment may depend on those competing interests. How to eliminate fear, frustration, stress, struggle and vulnerability even if your loved one is dying. You will get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control, power and influence in your situation. You will get real-world examples that you can easily adapt to your and your critically ill loved one's situation. How to stop being intimidated by the intensive care team and how you will be seen as equals. You will get crucial behind-the-scenes insight so that you know and understand what's really happening in intensive care and how you need to manage doctors and nurses in intensive care. And it's not what you think. Thank you for tuning into this week's Your Questions Answered episode, and I'll see you again next week in another update. Make sure you also check out our blog section for more tips and strategies, or simply send me an email to support@intensivecarehotline.com with your questions. Also, have a look at our membership site, intensivecaresupport.org, for families of critically ill patients in intensive care. You can also call me, find phone numbers on the top of our website. Also, have a look at our ebook section, and you can also get one-on-one consulting with me over the phone, via Zoom, via Skype and via email by clicking on the relevant tabs on the top of the website. This is Patrick Hutzel from intensivecarehotline.com, and I'll talk to you in a few days.